it is helpful to examine the posterior thorax and lungs while the patient is sitting, and the anterior thorax and lungs while the patient is supine. To proceed in an orderly fashion, we have inspection, palpation, percussion, and auscultation. Observe the rate, rhythm, depth, and effort of breathing. A normal resting adult breathes quietly and regularly, about 14 to 20 times a minute. Assess the patient's color for cyanosis and the hands for clubbing of the nails, which may indicate chronic obstructive pulmonary disease or congenital heart disease. In the inspection of the neck, you should watch out for contraction of the sternomastoid or other accessory muscles or supraclavicular retraction. Inspiratory contraction of the sternomastoids at rest signals severe difficulty breathing. Next, we should also watch for lateral displacement of the trachea, which may signify pneumothorax, pleural effusion, or atelectasis. With the patient sitting, the patient's arms should be folded across the chest with hands resting on the opposite shoulders. From a midline position behind the patient, note the shape of the chest and the way in which it moves, including deformities or asymmetry. Next is palpation. For the test chest expansion, place your thumbs at about the level of the 10th ribs, with your fingers loosely grasping and parallel to the lateral ribcage. As you position your hands, slide them medially just enough to raise a loose fold of skin on each side between your thumbs and the spine. Ask the patient to inhale deeply. Watch the distance between your thumbs as they move apart during inspiration, and feel for the range and symmetry of the ribcage as it expands and contracts. Causes of unilateral decrease or delay in chest expansion include chronic fibrotic disease of the underlying lung or pleura, pleural effusion, lobar pneumonia, pleural pain with associated splinting, and unilateral bronchial obstruction. Next is feeling for the tactile fremitus. To detect fremitus, use either the ball or the ulnar surface of your hand to optimize the vibratory sensitivity of the bones in your hand. Ask the patient to repeat the words 99 or 111. Palpate and compare symmetric areas of the lungs in this pattern. Identify and locate any areas of increased, decreased, or absent fremitus. Fremitus is typically more prominent in the interscapular area than in the lower lung fields, and is often more prominent on the right side than on the left. It disappears below the diaphragm. For the percussion, percuss one side of the chest and then the other at each level, as shown by the diagram. Resonance is replaced with dullness when fluid or solid tissue replaces air-containing lung or occupies the pleural space. Examples include lobar pneumonia, pleural effusion, hemothorax, empyema, fibrous tissue, or tumor. General hyperresonance may be heard over the hyperinflated lungs of emphysema or asthma. Unilateral hyperresonance suggests a large pneumothorax or possibly a large air-filled bulla in the lung. We could also identify the descent of the diaphragms or diaphragmatic excursion. Hold the fleximeter finger above and parallel to the expected level of dullness and percuss downward in progressive steps until dullness clearly replaces resonance. With the diaphragm of the stethoscope, listen to the breath sounds using the pattern suggested for percussion, moving from one side to the other and comparing symmetric areas of the lungs. For the examination of the anterior chest, The patient should be in supine position. Observe the shape of the patient's chest and the movement of the chest wall. Note for deformities or asymmetry, such as barrel chest, funnel chest, pedian chest, traumatic flail chest, and thoracic kyphoscoliosis. For the palpation, we should assess the chest expansion of the patient. Place your thumbs along each costal margin, your hands along the lateral ribcage. Observe how far your thumbs diverge as the thorax expands, and feel for the extent and symmetry of respiratory movement. Next is assessment of tactile fremitus. Compare both sides of the chest using the ball or ulnar surface of your hand. Fremitus is usually decreased or absent over the precordium. For the percussion, percuss the anterior and lateral chest, again comparing the both sides. The heart normally produces an area of dullness to the left of the sternum from the third to the fifth interspaces. Dullness replaces resonance when fluid or solid tissue replaces air-containing lung or occupies the pleural space. The hyperresonance of COPD may totally replace cardiac dullness. You should also identify the upper border of liver dullness. Percuss in progressive steps downward in the right midclavicular line. Use this method to estimate the size of the liver. For the auscultation, listen to the chest anteriorly and laterally. Compare symmetric areas of the lungs using the pattern suggested for percussion and extending it to adjacent areas as indicated. Listen to the breath sounds, noting their intensity and identifying any variations from normal vesicular breathing. Breath sounds are normally louder in the upper anterior lung fields. Bronchovesicular breath sounds may be heard over the large airways, especially on the right. You could also test for the forced expiratory time. This test assesses the expiratory phase of breathing. Ask the patient to take a deep breath in and then breathe out as quickly and completely as possible with mouth open. A forced expiration time of 6 or more seconds suggests obstructive pulmonary disease.